The first presentation is by Dr. Granfeldt-Ostgard from the University of Odense, Denmark. Please.
Thank you. And thank you to Maria Russo and Donatella and the organizers for inviting me. I'm really pleased to be here, and I look forward to not my presentation, but the upcoming ones. So the overall aim of my talk today is to discuss the importance of clinical epidemiology within the field of therapy-related myeloid neoplasms, and from a population-based perspective to focus on both risk studies of therapy-related myeloid neoplasms, as well as the potential prognostic impact of exposure to cytotoxic therapies in AML patients. And I don't have any disclosures. So therapy-related myeloid neoplasms are well recognized and often a fatal late complication occurring after DNA-damaging therapies for unrelated conditions like solid cancers, autoimmune diseases, and organ transplants. And the term treatment-related or therapy-related myeloid neoplasms has been defined entirely by medical history. It can be divided into subcategories, but these are rather arbitrary, which is underlined by the ever-changing blood counts used to define MDS and AML. So historically, therapy-related myeloid neoplasms has been characterized by, according to the preceding cytotoxic agent, and in general, alkylating agents and radiotherapy has given rise to high-risk MDS and AML with dysplasia and complex karyotypes, adverse risk cytogenetics, and also TP53 mutations about 5 to 10 years after exposure. In contrast, the topoisomerase 2 inhibitors may lead directly to AML with balanced translocations 1 to 3 years from exposure. However, with the increasing use of combination chemotherapy and the use of new drugs, different dosing schedules, it makes this categorization less clinically useful. The time from cytotoxic exposure to onset of therapy-related myeloid neoplasms varies by prior condition, which is of course associated with the most commonly used treatment regimens for the disease. In both of these Scandinavian studies, population-based studies shown here, the median time to a second cancer was similar for solid and hematological cancers. And in contrast, time from the non-malignant diseases to myeloid neoplasm varied greatly both within the cohorts as shown here, but also in between the studies, suggesting that other factors than MTX, which was the most common one, are important for leukemogenesis. Also interesting, in the Danish study, we found identical latency times for solid cancer patients, regardless of whether or not they received cytotoxic therapy for the primary cancer, which at least to some degree points towards, in reality, some misclassifications among de novo disease and therapy-related defined cancers. 20% of new cancers are second cancers, and some of these may have occurred even if the patients had not been exposed to chemotherapy or radiotherapy. Patient-related factors such as genetic susceptibility and environmental factors may modify the risk of therapy-related myeloid neoplasms in individuals. Causal factors for the primary cancer may also be involved in leukemogenesis, for instance, smoking. And finally, a second cancer may also occur just by chance. But these complex interactions between individual predisposing factors and exposure to cytotoxic agents are far from clarified. Over decades, we have witnessed an increasing life expectancy and a growing world population. And last year, 18 million people worldwide were diagnosed with cancer. With the advances in therapy and increasing use of leukemogenic agents, and a significant proportion of these patients will be considered cured, but it also potentially increases the population at high risk of therapy-related myeloid neoplasms. AML and MDS each represent about 1.1% of all new cancers, corresponding to an incidence around 5 per 100,000 person years, depending on the country or the registry used to publish on. With therapy-related AML accounting for about 5 to 10% of all AML cases and less in MDS patients, the overall incidence of therapy-related diseases is still very low. In a Danish population-based cohort shown here, we did not find an increase in the incidence or in the absolute numbers of therapy-related AML cases over about a 15-year period, here illustrated with the green bars. A recent and large SEER study from the US found an 80-fold increase in therapy-related myeloid neoplasms following childhood cancers over about 50 years. However, as alarming as it may seem, and devastating for the individual cases, this is actually equivalent to only 8 additional therapy-related cases per 10,000 person years. And whether this is considered acceptable must be held up against the increasing number of childhood cancer survivors saved by the cytotoxic therapy used. Also based on a SEER data set, Morton and colleagues showed how incidence of therapy-related myeloid neoplasms vary by the primary cancer. And in its study, the overall incidence of therapy-related myeloid neoplasms was also increased. And same was true for a Swedish study published by Nilsson and colleagues recently, and they reported an annual increase of about 4.5% for therapy-related AML. But these significant changes in treatment protocols for the specific cancers may not be reflected in therapy-related rates until years later. And it makes it really difficult to interpret these findings. So unless investigating large cohorts with results stratified by the preceding cancer type and with access to valid information on the specific preceding cytotoxic therapies, these overall results may be blurred. So distribution of the prior conditions treated with cytotoxic agents in therapy-related AML patients will vary by the population studied. And this is illustrated here with 2 different studies. A great study by Kaiser and colleagues based on 6 prospective large multicenter trials and the Danish cohort. And we can see here that in the Danish cohort, more patients with hematological diseases, including lymphoproliferative diseases and also representing multiple myelomas, were included in this cohort. And this is due to the fact that many of these patients are not offered or eligible for intensive chemotherapy when diagnosed with a second malignancy and would not have been included in a clinical trial. So as shown here by Swedish data on the right, about a quarter of AML, therapy-related AML cases follow breast cancers. And in contrast, lung cancers and prostate cancer patients are heavily underrepresented, considering the general incidence of these diseases. However, when illustrated here by some Danish unpublished data from an ongoing large study, I'll come back to in a moment, Prostate and lung cancer patients are almost 10 years older than breast cancer patients. And also when we look at on the right, the 5-year mortality, it's devastating. And few patients with with the prostate cancer or lung cancer will live long enough to actually experience a therapy-related myeloid neoplasm. So up to 50% of all AML patients are treated with curative potential, and about half of these are treated on trial. And it leaves 25% of all AML patients for trials to report on. And comorbidities such as the prior cancer, the prior cytotoxic chemotherapy, or organ dysfunction secondary to the prior treatment may prevent intensive chemotherapy and trial inclusion, especially for trials conducted by the pharmaceutical industries. So accordingly, characteristics of AML patients included in clinical trials have been shown to differ from the general AML population. And that is also true for MDS patients. And in terms of age, sex, ethnicity, and comorbidity, and also socioeconomic status, patients included in trials have more favorable characteristics. A study on the right, again, Danish patients, and in this case, liable for intensive chemotherapy, only at a time where an age-appropriate MRC trial was recruiting, found that patients off trial had more high-risk features, including poor performance status, secondary AML, therapy-related AML, and they had higher white blood cell counts and higher LDH levels. And this underrepresentation of therapy-related AML patients in the clinical trials may hamper the generalizability of treatment effects to these specific and important subtypes of patients. So randomized trials are, of course, superior to other study designs when investigating medical interventions. However, when it comes to less frequent diseases like therapy-related AML and looking at rare outcomes, many clinical studies are non-randomized, single-arm studies or single-center reports, and it prevents comparison of treatments and adequate confounder controlling. And not all research questions can be answered in clinical trials because sometimes ethical concerns may prevent randomization. And also when looking at risk, an ongoing observational or clinical study would require unrealistically long follow-up times and large populations. So observational studies do have a lot of limitations. However, if confounding and bias are adequately controlled and handled, these may have some advantages when studying diseases like therapy-related AML. The Danish Clinical Hematological Database includes the National Leukemia Registry and the Danish MDS database, and they include comprehensive amounts of data. And these data can be used and linked by the CPR number, which is assigned at birth or immigration to all Danish citizens. And using a population-based design in the Danish cohorts or the Danish populations, the risk of selection bias is reduced, and it also allows for comparison cohorts and match cohorts on an individual level. However, the quality of collected data is of crucial importance, and far from all leukemia registries and observational cohorts have been validated, and the completeness and accuracy of the data are in many cases unknown. The Danish Leukemia Registry was validated some time ago now and was found to include more than 99% of all AML patients diagnosed since 2000. And the data was very complete and accurate. And the MDS database was validated a few years ago with acceptable outcomes. The huge problem in Denmark is the limited access to molecular data, which is, of course, of crucial importance, and it's still kept at a hospital level. It is accessible, but not through major registries, and it's due to the GDPR regulation by mostly. Several studies on risk of therapy-related AML has been based on the SEER, and most of these are focusing on breast cancers. Recently, Morton and colleague again reported on adults 20 to 84 years old receiving initial chemotherapy and alive after 1 year from the primary cancer diagnosis. And they found standardized incidence ratios of therapy-related neoplasms were increased for all but colon cancers. They looked at 23 different cancer groups, and they found the highest incidence in sarcomas. Another study from the SEER found thyroid cancer survivors treated with iodine-131 therapy to have an increased risk of both MDS and AML, with 1.2 excess cases per 10,000 person years in this population. And finally, a Korean study, the authors found an excess risk of AML in patients receiving cytotoxic therapy, especially chemotherapy plus minus radiotherapy, and they found the highest risk in younger patients and in the first year following therapy. And they did not find radiotherapy alone to be associated with increased risk of therapy-related disease. So to date, there are only a few European studies. I have not included Italian studies. I hope they are included in the upcoming presentations. Here, a French study. And this is a study using a health insurance program database, and they look at 88% of incidence breast cancer patients. And the authors report on increased risk for AML in this cohort and even higher risk for MDS. They find similar time from breast cancer to the different types of myeloid malignancies. And when you look at the time of the highest risk, it seems that, as for the Korean study, that the risk of AML is highest in the beginning, whereas the risk of AML maybe at best stable, or it might even increase over time. So we have been working on a population-based matched cohort study based on the aforementioned registries. And we identified all Danish patients with non-myeloid hematological cancers and solid cancers, and we matched these 10-to-1 to the general Danish population on age, sex, and calendar year. And also we used type of chemotherapy and radiotherapy, and included the time of first chemotherapy or radiotherapy administration date as a time-dependent covariate. And the main aim of this study was to look further into whether all clinical defined therapy-related diseases are truly therapy-related, and to report on risks for patients stratified by the treatment and compared not only to the general population, but also to a group of cancer survivors not receiving cytotoxic therapy. And I won't be able to show you the exact results and the detailed results, but we did find here the overall preliminary results. We did find that patients receiving radiotherapy alone had the same risk as patients with the primary cancer, but no cytotoxic therapy. So at least, and this was mostly true in the cancers where, for instance, smoking was a great risk factor for the primary disease, and also for lymphomas and myelomas. And this may at least indicate that shared carcinogenic factors may be involved in this. So Ostgard and colleagues from Sweden found that therapy-related AML as well as secondary AML affected survival in younger patients. And also a hypothesis generating a smaller, I think it was Japanese study, suggested that preceding hematological diseases affects outcome depending on the specific disease. And in the Danish cohort, this study was actually conducted at the same time as the Swedish and just published a little bit later. Here we show overall survival for therapy-related AML patients. It's the red line is inferior when we look at crude survival to de novo patients. And on the right is some unpublished results showing for the therapy-related patients in the cohort that patients receiving radiotherapy alone, that's a green line, is maybe better or at least identical to the survival of de novo patients, which is the black line. So in this study, the median age for therapy-related patients was lower compared to de novo patients. They had more or higher frequencies of complex karyotypes, abnormal karyotypes, and but these patients were just as likely to receive intensive chemotherapy and complete remissions as de novo patients, as long as this analysis was adjusted for confounding factors. We found, just as the Swedish study, inferior survival in therapy-related patients younger than 60 years compared to de novo patients after 1 year and slowing down over time. And this was true when adjusting for confounders, including the higher frequency of complex karyotype and abnormal karyotypes. And it likely reflects some of the high-risk somatic mutations like TP53 mutations that we did not capture in this study. However, within the cytogenetic risk groups, inferior survival in the Danish patient was not significantly worse than de novo patients when adjusting for other confounders. And this was especially true for the adverse risk group. So the most recent WHO classification system introduces a more precise terminology and definitions, also modified to reflect the improved understanding of clonal hematopoiesis as a risk factor. Going forward, the most specific molecular and genetic diagnosis must be used, meaning that therapy-related cases will end up within, and some of them at least will end up within these TP53 categories, except they will have the demotion of therapy related to an appendix. And also MTX has been included or removed as qualifying to therapy related. And the Danish findings support these changes in categorization of therapy related diseases. Just to note, in our it was often RA patients had normal side and similar survival to de novo patients. So in conclusion, the trends in incidence of therapy-related myeloid neoplasms varies between cancer populations, with some decreasing and others increasing over time, reflecting changed therapies. There's strong evidence towards an increased risk of therapy-related myeloid neoplasms in most cancer survivors, with the highest risk found in younger patients and in patients receiving chemotherapy plus minus radiation therapy. Still, therapy-related myeloid neoplasm is a rare event, even in the high-risk populations, with a 10-year risk about 1%. And the prognostic impact of the therapy-related myeloid neoplasms is mainly due to the associated treatment, patients and disease characteristics, including adverse risk cytogenetics and high-risk somatic mutations. And some truly de novo patients may have been classified over time as therapy-related. So until further advantages, treatment of therapy-related myeloid neoplasms should be guided by morphologic features, cytogenetics, molecular characteristics, as well as age, comorbidity, and performance status. So a history of cytogenetic therapy, cytotoxic therapy alone does not withhold potentially curative treatment options for these patients. And finally, continuous clinical and observational research is, of course, needed in these patients to investigate interactions between patients-related factors and cytotoxic therapy, to identify effective, less toxic cancer treatments, and also investigate whether treatment alterations should be considered by algorithms, including pros and cons in high-risk patients when planning the primary cancer treatment. And finally, to investigate potential effects of screening for clonal hematopoiesis or myeloid neoplasms following cancer treatment. So thank you for your attention. This is just a picture from my favorite spot in the world, in Pradello, here in Italy. I'll be happy to try to answer any questions.
Thank you, Dr. Ostgard. Are there any questions? Any question?
I mean, they have been included now, right? And I think it illustrates that we just need to continue to surveillance. We might introduce new drugs that do a lot of good in the primary population, but over time we might figure out other side effects, including treatment-related neoplasms.
I'd like to ask you a question. You show the very interesting data on the breast cancer, and you show that the radiotherapy do not have effect of the secondary leukemia, of the therapy-related leukemia, and also the incidence was less than patients treated with surgical procedure. This is not for other cancer, and some people agree that the radiotherapy contribute less to the secondary to therapy-related leukemia. But I think the first cases of therapy-related leukemia were described in Hodgkin disease treated with radiotherapy. And then I think it is important the modality of the therapy of radiotherapy. And what is your opinion about the radiotherapy and the chemotherapy in the determining the secondary leukemia? The
data shown, our data with the incidence and the risk was not for breast cancer patients alone. We do have that data, but it was for all the patients included in the study, so all cancers. I think it's really important to try and figure out the amount of cytotoxic therapy and whether or not to include it as fractions of radiation, or it's really difficult because you get this huge amount of data and each receive different amounts, and some of the patient not receiving a lot is because they have a lot of comorbidities and already progressing, and so there's so much confounding and bias possible when doing these risk studies.
But on the other hand, it is certain that radiotherapy on the thorax in patients with Hodgkin disease in young women increase the incidence of breast cancer, for example.
And for breast cancer, I believe it's true, and I think our results suggested to or showed it too. So this was just the overall results, so it's confounding by some of the other. It's like the trend study that if you just pull a lot of different, some might pull one way and others might draw in the other direction. So we need to look at this was just because I can't really show unpublished results just yet. My PhD student won't allow it either. So, but when we do have the results for the breast cancer patients and the lung cancer patients stratified.
So, since your presentation was focused on epidemiology, I would like you to comment on issues of how do we account for competing mortality issues in this patient? Because of course, I think, like for instance, you say that the risk is higher in patients who are treated at a younger age. But it's also true that one of the main theories for therapy-related myeloid neoplasm is for the patient to have already, as a harbinger or future therapy-related myeloid neoplasm development, clonal hematopoiesis, which doesn't fit with a patient being very young, right? Because we know this is like an age-related kind of like issue. So my question is, a patient who is treated at 20 years has 40 years to develop a therapy-related myeloid neoplasm. So unless we don't like match or we do like some statistical adjustment, we might have like a reverse immortality paradox or something, right?
Yeah, and some of the studies do have that, not the ones I included. They do try to account for the mortality, which is very different in the cohorts. And that's why we did the matching and and we also used competing death as a competing risk. Yeah, and we also excluded patients when they developed a second cancer, which was not a leukemia or a myeloid disease. So you need to do something, otherwise you'll just get some really interesting results, but not reflecting the truth. Yeah.